focus on Guillain-Barré syndrome in this lecture. We've talked about myasthenia gravis, multiple sclerosis, and strokes. So what are some things that set Guillain-Barré syndrome apart? Again, I'm trying to prepare for the Nclex exam, so I'm going to touch on those topics. Now, Guillain-Barré syndrome, same thing. It is an autoimmune disorder, your own immune system attacking your nerves, causing demyelination, causing inflammation. Now again, the exact cause is unknown. Something is triggering your immune system to attack your body. Possible causes can include something like Campylobacter jejuni. This is very, very specific to Guillain-Barré syndrome, so make sure you know that for the Nclex exam. So the patient may be suffering from gastroenteritis, possibly suffering from some type of upper respiratory infection or GI infection. Again, this is very specific to Guillain-Barré syndrome, as opposed to MS or myasthenia gravis. Number two, some type of viral immunization, maybe vaccination against swine flu. Again, we have exposure to a viral pathogen or a virus. Again, number two, viral immunization. Number three, HIV. Or four, cytomegalovirus, Epstein-Barr virus, varicella-zoster virus. So again, we have an exposure to some type of viral infection. Let's focus on some clinical manifestations that you need to know for the Nclex exam. Again, I'm going to be very, very brief and hit you with the main things that you need to know. So number one, the thing that makes Guillain-Barré syndrome specific, or excuse me, the thing that sets Guillain-Barré syndrome apart from, for example, myasthenia gravis, multiple sclerosis, is that there will be tingling and weakness in the extremities, more specifically in the lower extremities, in the feet and legs. And then the tingling and weakness or paresthesia will work its way up towards the upper body. So that is very specific, that is very unique to Guillain-Barré syndrome. Again, tingling and weakness, paresthesia, in the feet and legs, and then working its way up. Number two, we have paralysis, or the potential for paralysis. Now, if the respiratory muscles are compromised, we have to worry about respiratory failure. So you have to make sure that you're always assessing respiratory rate, the depth of their respirations. You're checking their O2 sats. You're checking ABGs. Again, we are worried about respiratory muscles being affected by paralysis. So if that happens, you must be ready for intubation. So have that equipment available. Again, cannot stress this enough. You make sure that you are checking the respiratory rate, the depth of respiration, their O2 sats, ABGs, any changes you report it to the physician immediately. Number three, again, we talked about how the nerves are being affected, so the patient will typically have complications with ambulating, or they will suffer from an unsteady gait. Again, face is being affected, so patients will have facial drooping, difficulty with speaking, difficulty with talking, difficulty with chewing, swallowing. So this predisposes the patient to suffer from aspiration. So we have to be aware of that. Again, if we're going to be feeding the patient or assisting the patient with feeding, we must sit them in an upright position. Again, we want to check that gag reflex, provide thickened liquids. Again, we want to prevent aspiration. We've talked about two respiratory complications. Number one, aspiration, and then two, respiratory muscles becoming paralyzed or suffering from respiratory failure. So lungs, we always want to check out the lungs, respiratory rate. I cannot stress that enough. Number three, severe pain. Again, we're having the nerves being affected, so we have to assess for paresthesia, for the tingling, for pain. Now, this pain typically occurs or increases at night. We have to worry about number six, hypertension or hypotension. So again, we're always assessing our vital signs, looking at our blood pressure, looking at our heart rate. If hypotension occurs, we may have to give IV fluids. If hypertension occurs, then we may have to give medications to lower that blood pressure. Patient may also suffer from SIADH. If you don't remember this, go back to that lecture and review. Number 8, again, we have problems with our bowel and bladder control, constipation, bladder, or excuse me, urinary retention, or incontinence. Now, what are some diagnostic studies that you need to know for the Nclex exam? Number one, most specific, is cerebrospinal fluid. We will typically find elevated levels of protein in the cerebrospinal fluid, so make sure you know that for the Nclex exam. That is very, very specific to Guillain-Barré syndrome. Again, we want to check the cerebrospinal fluid, so maybe something like a lumbar puncture will be performed. Again, looking at cerebrospinal fluid and finding elevated amounts of protein. Now, typically, this elevation will occur 7 to 10 days post-infection. Typically, diagnosis is done on clinical signs. So what are some treatments or interventions that we need to know for a patient? Number one, plasmapheresis. This is typically done in the first 2 weeks. Number two, IV immunoglobulin or sandoglobulin administration. Number three, going on with our interventions now, again, we're always worrying about aspiration. Patient may be drooling a lot. Again, they're losing that ability to control their facial muscles. So we're always worrying about aspiration. Therefore, again, you always want to place your patient in an upright position. You want to have them flex their head forward during eating. Again, we want to prevent aspiration from occurring. Number four, we want to monitor their ABGs, their respiratory rate, their O2 sats. Again, we're always on the lookout for possible respiratory failure if paralysis of those respiratory muscles occur. Again, if respiratory failure occurs, the patient may require intubation, so please have all the necessary equipment for intubation readily at hand. Number five, we talked about how patients may have difficulty talking, difficulty communicating. Therefore, you also want to establish a communication system. You have to be able to communicate with your patient. Number six, we talked about how we're going to have loss of bladder control. So we're about urinary retention. If that happens, we must either perform intermittent catheterization or have an indwelling cath put in place. Again, this is if urinary retention occurs. So that being said, you want to monitor their urinary output. If they haven't voided, then you may perform something like a bladder scan and then determine if catheterization is necessary. Again, we talked about how the patient may suffer from facial drooping. They may be unable to close their eyes completely. So again, we want to provide artificial tears, something like methylcellulose. Again, prevent the eye from becoming completely dry. We want to protect that eye. We want to protect from corneal abrasion, corneal dryness, or irritation. Number 8, you can also start the patient on a bowel program. We talked about how something like constipation or paralytic ileus can occur. Again, patient is not able to ambulate like they should. They're remaining in bed for prolonged periods of time. This makes it very, very likely for that patient to suffer from constipation. Therefore, we want to take steps to prevent constipation, so you may initiate a bowel program. Also, if the patient isn't ambulating, if they're becoming more and more immobile, again, make sure you turn that patient. We are always concerned with the patient developing pressure ulcers or breakdown in the skin, so please always rotate your patient. Make sure that they're changing positions at least every 2 hours. Check the skin, any redness, any sores, any skin tears.